Hello, welcome to this episode of Case Bites. My name is Dr. Jay Mohan. I'm the program director for the McLaren-Macomb-Oakland Michigan State Cardiovascular Fellowship. And today we are going to be discussing acute coronary syndrome. So I had a patient that came into the hospital. They were 65 years old, presented with pretty typical symptoms of chest pain at rest. They described the pain as substernal and associated with shortness of breath and nausea. EMS was called from the patient's house after the patient actually experienced a syncopal episode. And when they arrived to the patient's house, they noticed that the patient was significantly bradycardic. They have pretty classic cardiac risk factors of diabetes, hypertension, and dyslipidemia. No significant surgical history. They were a smoker and no significant family history as well. So on physical exam, when the patient got to the emergency room, we noted the patient to be pretty bradycardic with a heart rate of 50. They had a marginal blood pressure of 97/55. They were alert and oriented, did have some evidence of heart failure with positive JBD, as well as bibasilar crackles when we auscultated their lungs. But they appeared warm and dry, so we weren't too concerned for cardiogenic shock, but definitely some concern for some associated heart failure. So this is the EKG on arrival to the emergency room. Whenever I look at an EKG, I always try to stick to an algorithm: rate, rhythm, axis, intervals, and any concerning findings. So looking grossly at this EKG, what I usually do to calculate the rate is I count QRSs. So 1, 2, 3, 4, 5, 6, 7, 8, 9. So 9 times 6. So the rate's somewhere close to 60, 58-ish. The next thing I like to do is look for activity, sinus activity. So usually to find P waves, I look at the inferior leads. So there's upright P waves in 2, 3, and AVF, and inverted in AVR, which is consistent with sinus rhythm. And then we look for our intervals. It looks like there's a pretty significantly prolonged PR interval here. So with patient being bradycardic, we're concerned for any heart blocks. So I think this is consistent with first degree heart block. I don't see any dropped QRS complexes. And when you look at the other intervals, there is some concern for some ST elevation, specifically in leads 2, 3, and AVF. So the inferior leads, and reciprocal depressions in the lateral leads. So consistent with what I just spoke to, we have a rate of 60, upright QRS complexes in 1, AVF in lead 2, consistent with normal access. We have sinus rhythm with some frequent premature beats. The interval, we did notice that prolonged PR interval consistent with the first degree AV block. And the ST segments were elevated in the inferior leads with reciprocal lateral changes. So at this point, whenever you have this amount of information, you always want to think, what would you do next? What is your plan? You kind of have to anticipate things in cardiology because there could be many different things that cause patient presentation. So this patient has pretty clear-cut ST elevation in the inferior leads. So in my mind, whenever I look at an EKG, I like to localize where that evidence of blockage or ischemia is occurring. And in this patient, they had inferior ST elevation. So my concern is that they potentially have some issue with their right coronary artery. And that is important because the patient's also relatively bradycardic. The RCA is really responsible for the conduction system of the heart. So if you lose perfusion to your right coronary artery, you can have issues like heart block or bradyarrhythmia. So that's something you have to be prepared to deal with. Other tests that I want to know is I'd obviously want to know their blood work, hemoglobin, thyroid function, kidney function. If he's had syncopal episode at home, having a CT scan before they go to the cath lab where they receive blood thinners is important in case they have some sort of intracranial hemorrhage or bleeding issue. And then we want to know what medications the emergency room physicians have already administered. Specifically, anyone with acute coronary syndrome or ST elevation, you want to make sure they've received aspirin, make sure that they've probably received heparin plus or minus. And then a lot of times we talk about nitro or morphine or oxygen. Really that's fallen out of favor, but a lot of times we'll see the patient if they have a lot of pain. We'll consider nitro, but it's important in this patient to notice that they've had an RCA involvement. So you have to be worried that if you give nitro, you drop their preload, you could potentially cause them to go into heart failure or cardiogenic shock. So that patient, like I mentioned earlier, already showed signs of heart failure. So that's of concern. So before I get back into the case, I really want you to understand what is a STEMI or what happens during a STEMI. And what really happens is you have a vessel and you have plaque formation that occurs within that vessel. And plaque is usually lipid rich. It consists of, really fatty lipids that occur into the vessel wall, usually what's called atherosclerosis or hardening of the arteries, that it predisposes you to having plaque develop in the artery. And then what happens usually is that the cap gets covered by an endothelial layer, creating a fibrous cap on the vessel or on that lipid plaque. And what happens over time is that plaque can actually rupture and expose those lipid contents, as you can see in this video, to the vessel wall or into the intraluminal space. And the body actually almost gets tricked into thinking this is a vascular injury and sends coagulation cascade factors, platelets to basically heal this plaque. But by doing that, it basically blocks blood flow, creating an acute occlusion of the vessel and therefore a acute ST elevation myocardial infarction or some degree of acute coronary syndrome. An important concept also when you talk about STEMI, when a patient presents to the emergency room, is we get a lot of information from that EKG. And I mentioned something about an inferior wall ST elevation MI is what we're dealing with in this patient. But with an EKG, you can use it as a map, basically. The inferior leads are 2, 3, and AVF. You can see elevation in those leads. You could be concerned for an inferior wall MI, which is usually the right coronary artery, as you can see in this diagram. If you have involvement of one AVL or the lateral leads in V5, V6, you concern more of a diagonal or circumflex involvement. And then if you have involvement in the septal leads or anterior leads, which are V1, V2, V3, or V4, you're more concerned for an LAD. So just having the EKG on arrival, you can gather a lot of information before you get to the cath lab to kind of understand where that acute occlusion may be occurring. So we took this patient to the cath lab, and as expected, this is what we found when we injected the right coronary artery. So we use guide catheters, which are larger catheters. Usually I go from the radial approach. We put a tube in the radial artery. We take a wire up to the heart, and then we basically take this catheter over that wire and we inject the arteries with contrast. And here you can see on injection of the RCA, there is a filling defect in the remainder of the RCA concerning for an acute occlusion or thrombus within that RCA. So the next thing we do is we take a 0.014 wire, which is about the size of your hair. It goes down the artery to try to reestablish flow. And here we could see there's still not very good flow even after placing that wire into the artery. So the next thing we do is use a balloon that we monorail over the wire to kind of create a channel to see if we can reestablish flow. And that's actually what we see here. We can see the proximal lesions probably where the acute plaque rupture occurred. But if you look closely, when we look at these angiograms, we really start from the beginning and look all the way to the end. And uniquely in this angiogram, you see a kind of hazing filling defect that's kind of moving back and forth down in the distal part of the vessel that's concerning for a blood clot or an embolic. Some of that blood clot that occurred in the proximal vessel probably kind of went down distally. So that's something we're going to have to worry about as we go. So during this case, I'm worried that, how's the patient doing? I'm looking at their blood pressure. I'm looking at their heart rates. And fortunately for this patient, everything remains stable. But in occasional patients, especially with inferior wall ST elevation MIs, we have to consider placing a transvenous pacemaker. We sometimes have to give medicines like atropine. These are all considerations that we consider doing as we progress through the case. So here, I'm giving some more injections to kind of understand where my wire is and what's going on in the distal vessel. It looks like there's a lot of clot in that distal vessel, and that's not an area I really want to stent. So I have to figure out a way to remove that clot. So actually what I do is I take a catheter called the intravascular ultrasound, or IVUS, to really understand and make sure that where my wire is, to make sure I'm in the right place, that I'm not in a dissection plane, and to understand if is that clot or is that plaque or is that something, I can go in and maybe aspirate out. So with the use of IVUS, I was able to understand that was some fresh clot. So I basically decided I needed to get the patient stable. So the first thing I do is I stent that proximal vessel where that original plaque rupture occurred. And now I have nice TIMI 3 flow, or very brisk flow through the RCA, but I still have that large filling defect in that distal part of the vessel. So that's my next plan, is how do I deal with that? So to deal with that, I decided to do something called coronary thrombectomy with a device where we actually basically take a large catheter that has a hollow tube on it, and we basically take a syringe and create a vacuum within this hollow tube, and we're able to actually aspirate or pull out that blood clot by doing this. This specific catheter was called an export catheter, and this is the clot that we actually removed in that distal RCA. This is actually one of the largest clots I've removed by using this form of aspiration thrombectomy, but it removed that large clot. You can see it's pretty well organized, but that was all basically what you saw in that bottom portion of that blood vessel. And this is the final result. We actually didn't have to stent that bottom portion of the vessel, and we were able to get away with just aspirating the clot out. So really nice TIMI 3 flow. I'm looking at the patient's EKG. Their ST elevations have resolved. The patient's chest pain free. I did notice that I had some little bit of distal clot embolization to one of the blood vessels down in the very bottom of the RCA that I'm going to leave alone and probably just treat with glycoprotein 2B3A agents like Aggrastat or Integralin to kind of marinate and dissolve that clot over the rest of the day. The patient's loaded with antiplatelets. I think in this case, we used a medicine called prasugrel that basically inhibits the P2Y12 receptor of the platelet to stop further aggregation of platelets, and also to protect that fresh drug-eluting stent we just put in. And the patient did extremely well, and it was actually discharged home the next day after they had an echocardiogram done demonstrating normal LV function, and after we knew they were tolerating their medications and their heart rate and everything else had resolved. So after the case, we got an echocardiogram done. As expected, they did have some inferior wall motion abnormalities. Their ejection fraction was noted to be 45. Typical normal ejection fraction is usually around 60%. Not surprising, in the setting of an acute MI, you get some degree of what's called myocardial stunning, or that heart kind of freezes itself to kind of heal itself over time. What we usually do is get an echocardiogram 3 months after putting a stent in and reassess where their baseline ejection fraction is going to be. Many times patients have that number resolve. The patient's labs are normal. Importantly, after the procedure, we want to make sure their hemoglobin's good. We want to make sure their kidney function hasn't changed, because we do use iodinated contrast, which can affect the kidneys. And then as I mentioned earlier, we started significant goal-directed medical therapy. We loaded the patient with prasugrel in the cath lab, followed by 10 milligrams a day after. Very important with antiplatelets. If you put a drug-eluting stent in, the guidelines recommend 1 year of uninterrupted dual antiplatelet therapy to protect that stent as it heals over time. Once the body has formed its own endothelial layer on top of the stent, it becomes part of the blood vessel, and you can safely stop some of these medications. But that first year is extremely important in keeping the patient on maximal tolerated medical therapy. Another important aspect is putting the patient on Lipitor. Very important trial called the Prove It trial showed that patients placed on high-intensity statins post-acute MI had a significant mortality reduction. So if you put them on a statin after an acute MI, the patient will live longer, not only for a reduction of lipids, but also has this pleomorphic effect of stabilizing plaques within the coronary arteries. So statin therapy is very important. We also put the patient on losartan, which is really indicated in patients with cardiomyopathies or weakened hearts. And we did not put the patient on a beta blocker due to baseline bradycardia. It is recommended beta blockers to be placed after an acute MI, but there is some recent data that was recently presented at the American College of Cardiology that suggests maybe not as important as we thought. But still, every acute MI that I have, I still place them on a beta blocker for now. And uniquely in the age of radial artery cardiac caths, we can send the patient home the next day. Pretty amazing. They come in with an acute MI. We put them on medicine, we revascularize them, and they're home the next day. And he's actually followed up with me in the office. He's in cardiac rehab. He's doing extremely well. Very happy with his results. And hopefully with some risk factor modification, this won't happen to him again. I hope you've learned a lot about acute coronary syndrome. Once again, to think about acute coronary syndrome, it's a spectrum of a disease. It starts at unstable angina, which is chest pain at rest, and it progresses to either a partial occlusion of the vessel, which is NSTEMI, to a complete occlusion of the vessel, which is STEMI. There's a lot more to acute coronary syndrome. This was an example of a STEMI presentation, but probably one of the more fearful things that patients have. Once again, heart disease is the number one killer in the United States, and this is one of the reasons why it does that. So, revascularization is important, but so is risk factor modification and understanding what medications patients should be on. So I hope you've learned a lot about acute coronary syndrome. Please follow me or send me a message on Instagram at Cardiology on Call or on Twitter at Dr. J. Mohan. I'm happy to answer any further questions. And I hope you can learn from this case and learn from future case play episodes. Thanks again.